Let's see. How we feeling? Give us some thumbs up, give us some silent claps. How we feeling? All right, we feeling good? That's exciting. We know folks are still trickling in, but we want to honor our presenters. I'm so excited to introduce our panelists. And this morning, I also want to take a moment just to celebrate the information, knowledge, and wisdom that has already been shared today. So if at any point when you are listening, you feel that something really resonates with you, I want to invite us to consider giving a little, right? We do this in open mics. I'm also an open mic poet and host, and we do that as a way of enhancing the connection. It gives more energy to the speaker. It's resonance. It's everything that we've been talking about, that deep human connection and experience. And so if at any point anything resonates, just go ahead and let us know. We can all vibe with that energy. It's great to have you all back, and we have some really exciting conversations ahead of us. In this panel, I just want to celebrate also that Dr. Joanne Elizabeth Wescott just arrived, literally on her flight, so she just was taking a few minutes to be present, but those moments that we can adjust, right, an agenda for a few minutes to have a humanizing moment and experience, that's what the HEAL conference is really about as well. And so while we have like these time frames, we just want to thank you all for being flexible, for coming into the room on time, but also honoring that sometimes we make adjustments to honor our human self. So thank you so much for that. This session is called Artificial Intelligence and MedTech Post-Pandemic Implications. The advent of artificial intelligence provides many possibilities within the medtech field that address the challenges of the healthcare industry after the pandemic. This session attempts to answer the questions, what role does AI play in accelerating the development of medtech? Please welcome the session's moderator, Dr. Joanne Elizabeth Wescott, and our renowned speakers, Mark Ganott and Dr. Aakanksha Pandit. All right, please give them a round of applause.
Hey y'all, thanks for joining us. We're thrilled to have Dr. Joanne here, and honestly, Aakanksha and I were afraid she was going to make it. Oh, I apologize for using my mic. So I just wanted to, wow, that is loud. Thank all of y'all again, but as I was saying, Dr. Aakanksha and Dr. Joanne, so they're the smart ones, but we all have a very interwoven background. Like Dr. Aakanksha and I are both neuroscientists, and Dr. Joanne, like the two of us, is extremely interested in using technological disruption to expedite clinical outcomes and to mitigate cost functions, which frankly is one of the largest barriers and something that we're very interested in kind of fleshing out how AI and MedTech is really about how giving clinicians back their time allows them to personalize this experience of patients and ultimately is going to push us forward to the next chapter of medicine. But I'll let Dr. Aakanksha talk a little bit more about what she's doing because it's dope.
Hi, everyone. This is Dr. Aakanksha. I am from India. I have done my master's in neurological physical therapy from University of Pittsburgh in US in 2022. And I am an aspiring physician neuroscientist. My main goal, I am very research-oriented, and my major area of interest is neuroregeneration and neuroregenerative medicine. So kind of trying to focus on Parkinson's, Alzheimer's, and hopefully to come up with a diagnostic tool and a treatment very soon. Also, ever since I was in my undergrad, I was a part of multiple research projects, especially after the pandemic. It was more like I was more inclined towards knowing why and what is happening exactly, because this virus had a lot of neurological complications associated with it as well. So I published 2 papers. One of it was, I was trying to kind of find what is the correlation between COVID-19 virus and the Guillain-Barré syndrome, which is basically a chronic neuropathy which cripples the patients, and it actually leads to paralysis. So that was one literature review wherein I kind of looked up at the literature, at the existing literature, and to my surprise, there was very, very little literature that was existing with respect to this particular virus, because this virus was so new that everyone was kind of trying to find out what are the potential outcomes, or what is going to be the potential predictor, and how are we going to deal with it? And I think AI has been a game changer, especially after pandemic, because it kind of forced us to to reinvent ourselves. We were forced to look at the alternative methods and alternative pathways, especially in healthcare, because we did come up with this digital model of healthcare, which was super helpful. And the best part is we still continue to use it as a very important tool even today, after the pandemic. I'm going to talk more about the glove, which we have come up with, but before that, I'm going to let Dr. Joanne talk.
Just to try to mirror off a little bit of what my colleague has shared with you. We come out of a 3-year of trauma. We've come out of a 3-year of mental anguish, as well as pushing us ahead of ourselves with AI. I saw it for myself after 10 months in the field. I am a registered nurse in my career background. I have a doctorate in strategic leadership with concentration in healthcare. And I saw from the inside how AI was significantly used, how it was beneficial, how it can give data in such a real time that would be beneficial for us. I saw where when families could not come in, and we had to rely on technology. We had to rely on typical FaceTime. We had to rely on some type of device to be able to communicate. And then as fast as we were getting people in that were dying, literally before they could almost be diagnosed per se, we needed to get data at a speed of lightning. We need to get concrete, accurate data. And with AI, this development can serve for severe cases. It can predict early on who is at high risk for COVID-19 diseases as well as other diseases. And we also can be able to use the AI technology to even give us the data of equipment. When we need those equipments that come in, and especially in certain regions, we can have that readily at hand to be able to expedite what we need, such as our PPEs and our vents, as well as using AI to develop other unique tools that we can use in this time of our need. And with that being said, you can take it from there.
I'm so glad that Dr. Joanne talked about equipment, because it's something that we all were talking about immediately. Is one of the major bottlenecks in MedTech is you don't have good enough information. You know, GIGO is a data science term, garbage in, garbage out. And my background is neuroeconomics at Emory, where I was studying the mesolimbic dopamine system, which is actually what she also studies, but in very different ways. And I was looking at suicide and ketamine, so a lot of mental illness and the early psychedelic research, and then pivoted kind of into doing cannabis economics when I was getting my MBA and doing neurogenomics. But now, and the reason I bring all this up, is now I do a lot of advisory work for diagnostic companies, biopharmas, and medtechs. And so even though my background's aggressively biopharma, I'm a neurogenomicist, which is pretty much the two halves you have in biopharma, drugs and genes. I find that most of the people I work with are actually medtech companies. Because again, we just don't have the capacity to get these multi-omic and syntheses, Genomics are fantastic, but they're way better when you put on metabolomics and proteomics and epigenetics and layer them all in. And frankly, I'm a big fan of ICER, which is incremental cost effectiveness ratios, because I'm a pharmacoeconomist, and with AI, not only can we predict who's at high risk, which is going toward clinical decision support tools, something that I've spent basically my entire career working on, which is what she's talking about, which is just like, hey doc, here are some questions you should ask, and based on the answers, we think X, Y, and Z. But also, you not only give them more time, you, like you were saying, open up entire new avenues for data understanding. Yes. And data points that they are sort of meaningless to humans, even brilliant researchers who spend 20, 30, 40 years, women like these two, it's still easier because you need a team of experts to fully bring it all together. And so a lot of what I do is fundraising and commercialization strategies and mostly in women's health, focused on like endometriosis, an area where there was only $16 million in NIH funding last year. And so, for comparison, diabetes affects half as many people and is 2,287 times funded better. And it's like, well, how do you compete against that? How do you get the capital to get a liquid biopsy diagnostic, which might cost $1 to $4 billion, when you can't get somebody to put up $16 million a year? Well, you use AI and hope that at least that number goes down a little bit. And not only are you able to get new cures, but as she was saying, and as she'll talk about, you can take what already exists and get the optimal form of it. So actually, Aakanksha has what I think is one of the coolest inventions, because one of my good friends has the exact kind of nerve damage that Aakanksha's thing works with. And that's why I'll let her talk more about it and how it's one of the best use cases for a digital therapeutic in a post-COVID world.
Sure. So talking about this new technology and incorporation of AI in the treatment protocols, I think it's important to kind of make use of the existing technology wisely, making the optimal use of the technology to make a difference in the patient's lives. Looking at the post-COVID period, everything was, as I said, everything shifted to this digital healthcare portal, and we were kind of forced to treat the patients remotely because hospitals were flooded with patients. Only patients who were very critical needed to be prioritized. So we did come up with, and one of the most common complications of COVID was stroke. So we did come up with a solution incorporating AI to kind of make sure that people did get that treatment that they deserved even after they were discharged from the hospitals. So this is a smart glove kind of a rehabilitation tool. It has the AI sensors that kind of detect even the slightest of hand movements. It comes with 21 different games. So the way it works is that these patients play these games. And while they are playing these video games, they are kind of, like we are targeting the specific hand movements which are needed. For example, the movements focusing on flexion, extension, or supination, pronation. All these various moments which are needed are focused using this particular software. Also, another important thing about it is the way it works is because we have incorporated two things. One of the principles is talking about the reward system. So as Mark was just kind of playing with the hanky, we know that when given the right kind of a feedback, your brain kind of knows what is it that it needs to do and what is it that it doesn't need to do. So every time you kind of miss the hanky, your brain kind of knows that this is something which is probably not helping me. So the best way, next time when I'm going to try and focus and kind of work on my fine motor movement in such a way that I get a grasp of this hanky. Every time my brain kind of does this, it is getting a positive feedback. And once I get a positive feedback, my brain is going to try and repeat the same movement because now it's rewarded with dopamine. Dopamine is something which we have very in common. Mark's research also revolves a lot around dopamine. So as I said, that because of incorporation of this reward system, the patient is kind of motivated, which is most important thing. And how cool is it to get treated while you're playing a video game? Also, something that makes this glove stand out is that it has 3 channels of biofeedback. First is the visual feedback, second is the auditory feedback, and third is the tactile feedback. And as you guys know, that stroke kind of could affect all 3 of them depending on the location and the extent of damage that has happened. Another important thing, which is very related to the dopamine principle that I just mentioned, is neuroplasticity. So the more you kind of try to do a specific task, the better you get at it. So it's more of like when we were kids, we were told that practice until you're perfect at it. So the practicing aspect is what is the principle of neuroplasticity. It's more of something, if you want to get better at something, you have to make sure that you do it repeatedly. And this is the same principle which has been also incorporated in this particular AI solution, which doesn't, it definitely makes the treatment session more fun, but at the same time, we are trying to incorporate all the basic neuro principles and make sure that the patient is being efficiently treated. There's also a great advantage to the clinics as well because it is definitely covered by the insurance companies. It has this biofeedback CPT codes, which are covered by the insurance companies. So even clinicians are at a great advantage, and the hospitals as well. I'm going to let Mark take over because he can explain this aspect better.
She's deferring to the pharmacoeconomist because my whole job is about outcome cost. So as she pointed out, the glove actually expedites the time to treat by 2.5, which time to treat is the biggest enemy of any clinician. As Joanne was saying, people died every day of COVID. My background in suicide, every time you haven't cured someone, they have suicidal ideation, you're risking losing them. My friend with the stroke hand, it's been 6 years now. If he had gotten the glove right after, he didn't have a stroke, but he had nerve damage right afterward, he'd probably have way better outcomes. But we can't figure out how to optimally use the resources because there's an extremely high cost to figuring out what's the optimal usage. And that's where an AI comes in. As Joanne was saying, and as a conscious thing does, it's basically like an imperfect coach. I was a lacrosse goalie for 10 years. So for me, throwing something up and down and catching it is generally pretty easy because I'm not even getting shot at the point, and it's a lot slower than a ball. But I had a coach who every time I had a slight motion wrong would be like, that's wrong. That is what her glove does. That is also what clinical decision support tools do. But instead of doing it for motion outcomes, they do it for patient outcomes. So if you're diagnosing someone or trying to diagnose someone, we are able to train these large models to look at volumes of data. And basically, you get all your experts to upload their brains. It's just like you have the best coach in the world, because it literally is, looking over the clinician's shoulder and going, hey, based on this data, maybe we should look differently. Now, I have a particular importance in that in women's health, where often women are gaslighted and just not listened to. And so one of the biggest things is the ability to have clarity from all perspectives. Because at the end of the day, there's still a lot of subjectivity, especially in like mental health, where I kind of cut my teeth. But with neurogenomics, we're starting to pare that down. Well, what is neurogenomics? It's just huge data sets that we're using very powerful computers to look at. And that's why if you're in neuroscience, you're super wed to all of these medtech innovations or any of these big data science fields. But these big data science fields are where we're going to get the biggest innovations. Like when I entered Emory in 2013, fMRIs were finally becoming cheap enough to get that data. And basically, it is so much better than everything else that they're like, wow, we had a neurological explosion from 2013 to like, we're still kind of experiencing it. Because for the last 10 years, we finally can in real time see what someone's thinking. Where is their brain lighting up? And then you can take better computer models and go, okay, so like electroconvulsive therapy, we just actually found 3 weeks ago a better way to do it using fMRI because we used machine learning to go, oh, we've been off by a micrometer, and that actually affects outcomes by 30%. This is just the tip of the iceberg. We are just starting, but ultimately the bottleneck is money, and it's the diagnostics to get us this data sets to throw the AIs over, which I think Joanne has a lot of thoughts on because she's got a lot of experience.
With that being said, just think about with genomics, if in real time we can get the diagnosis of the patient right there, we can get the medications that the patient will need. So it's going to serve a huge, huge amount of resources for us. But also with that, we have to balance the scales because of HIPAA compliance. So where are we at right now? How much HIPAA compliance do we have? In the real world today, when it comes to data, I mean, you can stroll on your phone and you can search for something, and before you know it, it's giving you the information back of different avenues of what you're looking for. So going forward, I don't know how much HIPAA compliance we will have, to be honest, but the most important is we need to have the data to be able to better serve the patients and to crunch the time to be able to save lives, and to be able to be more efficient and have the accuracy of the resources that is there. So we are in that time right now. We are in the real time for the future. And hopefully we can embrace this and we can find a cost-effective way around it, but there should be no amount of money that's more value over a human life. And with that being said, we will have to put away a lot of our biasness about, oh, but everything is coming into being into the digital world. Well, my friends, we are in the digital world. We are in that time now, and it's no going back. It is no going back. Everything is fast now. We need to have the information now. We need to be able to do this now. And the experience that we've all been subjected to with the COVID-19 has put us into a position where we're in warp speed. Okay, we need to find solutions. We need not to be caught in this, again, where we don't have the resources, we don't have the technology. And I mean, and the technology is there. It's sitting right there, right in our faces. We just need to go ahead and access it and use it and just put it to use. My colleague, when she talked about her glove, we need to go ahead and get the data studies on that. We need to find out how efficient it's going to be. And it sounds like to me it would be really efficient for someone that has had a stroke, that has not have the limitations of using their arms or their hands. I mean, you don't know until you don't have it. But when you can have something as unique as this that can readily go ahead and get things pumping and going and not lose time. The traditional method of the stroke and the exercises that we had with physical therapy, I'm not kicking against the grain, but now it's time to move it up, is to warp speed it up. And using this glove, I implore upon you to take interest in this. This is a move of the future. And with that being said, I'm going to let her close out, because this is an invention that needs to get out, that needs to be shared, that can be used, and it's nothing like having a proven tool. And so I'm sure my colleagues, my clinicians, they will be ecstatic to get their hands on this.
So there have been almost 10 RCTs that have been conducted, and surprisingly, as compared to the traditional physical therapy rehab, this has proven to be 2.5 times efficient and faster. It did address the spasticity, which is very commonly seen in stroke patients. So we were able to kind of reduce the spasticity. We were able to improve the fine motor movements and the fine motor skills in these patients. We were also able to have a positive impact on their mental health because of the video games and the dopamine system that I just kind of mentioned. This mechanism also kind of helped them to get a better psychosocial well-being. So this study has been published, and we are excited to kind of start more RCTs here in the US and kind of see how, and especially also target the other patient population, not just stick to stroke, but we would be excited to see how wonderfully this is going to work in even other conditions like neuropathies or multiple sclerosis, patients with Parkinson's disease, wherein motor function is one big challenge. So I would be happy to kind of get in touch with hospitals or clinicians who would be interested in starting these clinical trials. And we would love a feedback from you guys, because we can always incorporate the inputs and come up with something which is even probably more efficient.
Wonderful, wonderful. With that being said, I have already shared a lot of this information with some of the well-known hospitals that we have here in the U.S., with some of the clinicians that I've had privilege to work with over the years. And when you're able to share the information, I can put you in touch with them. We can get the information to them. And these are the teaching hospitals. These are our trauma hospitals. And they would be elated to be able to have their hands on the device. And if anyone wants to collaborate with her afterwards to try to find out a little bit more information to share in your area, please do that. And with that being said, close us out.
I'm always thrilled to hear about innovations on a personal level, because as Dr. Joanne said, there's no amount of money that's over a human life. And so realistically, when we are incapable of efficiently doing research, we're not just burning money, we're letting people die. You know, it's really that extreme. Like, I remember in business school when my friends were like, oh, whatever, don't take it too seriously. We're not doctors, our work doesn't matter. And I'm like, okay, but pharmacoeconomics does matter. Research matters. AI interventions matter. And being on the cutting edge is no longer just a privilege, it's almost a mandate to fully give people the best in-class care. Yet we can't do that if we are biased to limit to only what our own minds do, right? Even the most brilliant minds in the world need help. Because it's to understand something like what Dr. Aakanksha or Dr. Joanne did takes decades, you know? For me to do pharmacoeconomics, I really needed 3 separate degrees that have something to do with each other, but cover the gamut. And I still call my pharmacist friend every time I'm doing basic analysis, like, hey, bud, what's the LexiComp on this? And so with an AI, you don't have to have a network of experts. You already have them uploading their brain. And so I really see like the bottleneck right now as being investors have yet to get it. See, they're so used to the last 10, 15 years where we didn't have these multi-omnics or these next-gen screens but really we had them. That wasn't the problem. It was that we didn't have the ability to process all the data because they're like, well, this is way too much data for any one person. It will take me a week to look through one patient. I'm out. And that's why clinical decision support tools, that's one of the reasons I work in them, but also why I think that her glove to Joanne's COVID, I believe someday they're all going to be part of clinical decision support, which just going to be ubiquitous. Like right now, we have Siri, right? How is that not the first step? As somebody was talking about the last take, the physician has been supplanted as the top person in the medical ethos hierarchy. And if you consider this, then you have to also remember that 93% of basic science is VC backed. So these people who are mostly old white men are the ones who are trying to make calls on this, but a lot of them also don't really have a biopharma background. And so when you talk about where we are in a post-COVID world, digital therapeutics have finally come to the fore. And yet there's so much reticence because people are like, what are digital therapeutics? Why do they matter? Even though they have the best cost-effective outcomes almost universally. A great example is in postpartum for women, there are a bunch of apps that have them do exercise that recover, and they save I think it's $68,000 a woman. And it goes up, and that's just at 3 people an app because physical therapy is expensive. Having to go in is expensive. Or as Dr. Aakanksha was saying, when people don't feel great physically, it really affects their mental health. At least we know in endometriosis and postpartum, the correlation is something like a 40% diminishment in mood based upon physical symptom severity, so up to 46%. But generally speaking, the more symptoms you had, the more depressed these women were. It's no different than anything else. And it's partially because cortisol obviously leads to depression itself, like the inflammation hormone, but also there's a reason the best antidepressant is working out outside. There's so many aspects to being able to have autonomy. It's something called embodied cognition, which is the theory that our sense of self is our ability to manipulate the world around us. And when it gets harder to do that, we start to lose part of what makes us human, that at least our brain views it. Embodied cognition says, my idea of the brain stops where my hand touches this bottle. With Aakanksha's research, the embodied cognitivist will actually begin to see their own hand and the glove as one. It's just, just like you play lacrosse enough, anything else, your stick feels like part of you. You put a stick in my hand to this day and I'll catch a ball. It's just second nature. But that's fantastic, but it's also okay, it took me 10 years to get there. What if we had an AI that could expedite that? And so there are all these different dimensions, but what kind of ties them all together is this idea that the more time we can give clinicians back, the more time they can spend personalizing their treatment, talking to people what they really feel. And with clinical decision support tools, they have the capacity to know exactly what to ask in whatever way that may be, and then to execute on it by sending them it, having an AI say, okay, most of your patients are good except for that one. That one needs more help. And you're like, cool, we're gonna spend more time with you. And because of that, I really think that this is the final frontier in terms of what we're about to do with genomic editing, right? Because gene therapy is amazing, but it's really hard to know your targets. With multi-omic roll-ups, with epigenetic manipulation, we are on the cusp of being able to democratize and essentially decentralize trials in a way that everyone, everywhere, will hopefully soon have access to cheap diagnostics, because a lot of times it's cheaper to treat someone for a disease than to let them suffer. And we are almost to the point where that's going to be true for not just a few things, but almost everything. And the only gap left is that which AI will help us end.
You're so correct with that, because just imagine as patients when you're lying there and you're waiting for a test. The test, oh, you're going to go for a test this morning, and it's prolonged because whatever's happening with the machine is down. Oh, waiting on the doc to come in, and they come in to speculate that you may have XYZ, wherein if we had this AI technology, this tool, he would be so confident, or she, to be able to precisely say, you have this, and we have the medications to do this and that. I mean, it's just phenomenal just to be able to have things move much faster, because time for certain disease processes is of essence. We don't have a lot of time to wait for the results to come back in, and then we have to go back and retest it because it's inaccurate. There's an issue with the samples. So the wave of the future, I'm just so happy that I can be a part of this, that I can see lives come out of the bed, that can come back to some type of normal life, to be able to benefit from this AI. For genomic, to be able to say, oh, with the symptoms you have, it's not COVID.
It's not COVID.
It's not COVID.
Which you get.
And I would be so elated to hear that it's not COVID, you know. But just not to make light on COVID, I was sharing with my colleagues, and then we'll close out. I did 10 months into the pandemic, and with those 10 months into the pandemic, I walked past gurneys in the hallway because the morgue was too small to hold the number of people there. And it was just mind-blowing, again, mind-blowing, just to hear the wails and cries, not from families, but from the colleagues, and because we took an oath to save lives, and we could not fathom the number of lives that we were losing at that time. And we was just pulling our hairs out, trying to figure out what is going on, what can we do? And myself, I had promoted, as they say, working in the office, working in case management, and so it was all hands on deck. And so we had to go out and get back bedside nursing and get back to the grind and get in the trenches, and that's where the real fight was at. And I mean, to see some of our well-known clinicians break down, and as well as my fellow colleagues in nursing, it was tremendous to see that. And my mental is intact somewhat, to the point that I want to see something better for the future, that we don't have to wait days and days and people on the vent. So I think we may have some questions now. Yes.
I love everything that you all are talking. How are you getting insurance companies to work with this? I do it. I go, hey, y'all, like Endo's a great example. It's $1,650 on average, $1,650 a month on average for women's direct and indirect costs. And their direct expenditure to the payers is something like, oh God, $38,000 a year or something. And you're like, hey, y'all, if you diagnose women with endo, you can get them treatment protocols that cost like $4,500 a year. So you save like 30 grand. Do you like that number? And if you say no, I'm just call your investor and I go, hey, you know, the people you're investing in like aren't really fiscally responsible. Maybe you should talk to them about that. And the investors go, what is this? I don't like that. The insurance companies are hard to move, but a lot of when you hire a pharmacoeconomist, my entire job is to help people do the right thing by saying, look, the whole world's better off if you treat people and listen to them. Just do it. You know? Okay, awesome.
Any other questions? Any other questions?
Good morning. Great panel. So my question is, so my background is in software engineering and control systems engineering. I worked in automation and AI for about 10 years, and I lead a health tech company. So we started deploying a very basic MVP of AI. My question is, you mentioned investors don't get it, and I agree with you. How can we continue to destigmatize AI and ML so the people that are in positions to drive resources and funds to research and projects can continue to do so?
Unfortunately, at least in my experience, there's two kinds of investors, and maybe a quarter of them are MDs or PhDs, and they're just savagely good at science. They get it. You talk to them. They're going to grill you on your PubMed. You better drop PubMed all day long. The second you deviate from PubMed, they're like, you're citing Frost and Sullivan? I don't care. They're easier to talk to because they get it. You send them your scientist and probably a pharmacoeconomist, honestly. There's a reason I do a lot of investor relations, because they want someone who's going to speak both money and outcomes. And if they're just money, you just focus on money. You know, when I do women's health, investors don't want to invest in women's health. Women get less than 1.8% of VC funding. Women's health is paltry funding. So I'm like, hey, y'all, I have a life science deal for you, and here's the multiple on invested capital. Do you like this number? They're like, oh, yeah, it's great. What kind of life science company is? Bro, do you care about life science? You hate science. I do science so you don't have to. And then we come up with complicated models that de-risk the asset by showing that, hey, here's your willingness to pay. Here's what your total addressable market looks like. Here's what your patient burden looks like. Here's what your payer burden looks like right now. You synthesize it and you give it to them in their language, Because like, it's a joke Amy Schumer makes, right? Like, oh, why is no one funding endometriosis? Oh, because it affects women. That's not gonna change. Investors are baked in. It's mostly old white dudes. There's a, it's really, no, it's like 87% old white dudes, 60% of them went to Stanford, Harvard, or UPenn. And so like, you are not talking about diversity. It's not, you have to go to them and speak their language and go, do you like money? Of course you do. You're at a private equity firm. All you care about is money.
And if you put a good proposal together, we're dealing with our big guns, our government. Put together a good proposal and have data in the proposal.
Yeah.
And if you have data in the proposal, the government will entertain that. But they, when you approach them with wanting to make changes,
They don't care.
you have to have something in black and white that's proven, and the numbers need to be there. So just having conversation with them is not going to get it. We need to have it, a good proposal so we can approach.
Qualitative and quantitative ROI.
You need that.
Yeah.
That's the proven, that's it.
It's poet and quant. It's both emotional and like the science. Yeah, exactly. And you can get some investors care, but it's a lot rarer. Like family offices care more than VCs. VCs are just like, what? I don't even know what VCs invest in. PEs actually invest in outcomes. So part of it is you look for asset classes where people are driven by results and you go, you don't care about anything but your returns. You're not going to be biased. Like VCs will be like, oh, it's a woman of color. We're just not going to give her as much money. We're just going to discount her valuation. We're just going to do this. Oh, a woman invest in that woman literally lowers your valuation to have another woman invest in it. Whereas if somebody like me invests in the same thing, though it won't get changed. But so, you do both. And you try and find the people who care and you appeal to them when they have a soul, but a lot of them don't. So you just give them what they want, which is the numbers. Because ultimately, and the other thing is, it's their job.
Exactly.
It's their job to make money. So even if they want to help you, like I'm not a fund manager, but I work with a lot of them. They live and die by their returns. So it's like, at the end of the day, some of them want to help and they can't. Make it easy for them. Give them everything they need to be like, this is the decision I want to make. It's going to help everyone. My backer is going to be happy, and we're going to make money.
Just like, for example, with the glove, we're going to use the data. We're going to use a strong proposal with statistics that's there to be able to make this work. So we have to prove ourselves. And so we'll prove ourselves with this glove.
Yeah, so basically to kind of prove, you just need more and more RCTs is what, at the end of the day, it's more of like publishing the research, publishing the data, and kind of just trying to prove that, this is beneficial for patients. And so that's the end, like that would be the end goal, to kind of collaborate and get into the healthcare system and try and start as many trials as we can.
Remember, you want to de-risk the asset, because what do trials mean? What does data mean? It means that they think they're not going to lose their shirt investing in you. And if biotech, so generally SaaS, right, software means way better returns, it's way less risky, and you exit faster. So you have to give them very strong incentives to go against money, because they're making probably a little less per year than if they invested. But you make way more of a difference, so you just have to come up with every lens possible, synthesize as best you can, and then try and read the room and be like, what do they care about? What kind of investor? My favorite thing is to be like, do you like science to start? They're like, no. I'm like, good. Because then you can just talk about money. Or if they're like, oh, I love science. You're like, great, I have so much science for you. Like, make it easy for them to make the world a better place. That's all we're trying to do.
Let's give them a good job. Do we remember that? Good job. We learned this earlier. All right, let's try it together. Good job, good job. Good job, good job. G-O-O-D-J-O-B. Good job, good job. Remix, muy bien. You ready for muy bien? It's the same thing, but we just spell in Spanish. Okay, I'm kidding. We're going to spell it in English for this first one, okay? Muy bien, muy bien. Muy bien, muy bien. M-U-Y-B-I-E-N. Muy bien, muy bien. Thank you so much, Mark, Dr. Joanne, and Aakanksha. It's such a pleasure for your insight, meaningful conversation that I hope continues throughout the day and the weekend. Thank you so much.